Welcome back to the Long Defeat. Today we've got a good friend of mine. This is Daniel Schaub. He is a husband and a father, soon to be of two. He is a BSN RN. He's worked as a nurse in oncology infusion centers in different places in the US for the last 8+ years, from floor nurse to charge nurse. And we have known each other. Dan, I was thinking about this the other day. We've known each other for going on 11 years, uh,
Is it
from
Discover?
freshman year
Discover
of
GCU?
college. Discover GCU. That is
Man.
so wild. Yeah. From Discover, where I met you and Kenna, to Res Life, to Dutch Bros, to healthcare. Uh,
Yep.
Dang, dude. I don't know. There are not a lot of people who have known me through all of that. So, thank you. And also, I'm so sorry.
Hey, it's been fun.
Yeah, it's been a ride for sure. Um, yeah. So you know what this is, what the long defeat is. Mostly just getting a picture and an understanding of the human experience with the window into that being suffering. And I was kind of hoping that you could give us a picture of what a patient's experience is like with a cancer diagnosis, especially the patients that you see, which you have a good, pulse on what they see. And I think if we start here from like a 30,000 foot view, we can zoom in tighter later. Um, so maybe if you could tell us the story of a patient who comes through. How do these people find out that they have cancer? And
Yeah.
yeah, run with that.
Okay. Well, to be perfectly honest, I'm a little on the back end of when they find out, how they find out. Um, from my understanding, typically it's like a emergency room. They've had a new symptom or a new concern, and that's typically where things start. They get a scan, they get blood work, they get all the above, and um, that entail turns into the diagnosis, and then they get referred to the oncologist, and um, they'll sit down with the oncologist a couple times before I even meet the patient. So, from that perspective, um, I think they've done a lot of their processing. Well, sometimes they've done a lot of their processing before they get to me, because when they get to me, they're there for their chemo. And so I bring them back from the lobby and sit them down in a comfy chair, surrounded by, we have 30 chairs in our infusion clinic. So they're not super far apart. So there's no secrets in the infusion center, which HIPAA related. Still don't know how we get away with that HIPAA wise, but
Yeah.
but they sit down with me, um, and then depending on their diagnosis and the treatment regimen they've discussed with the oncologist, I'm there to walk through their treatment, give them their chemo, educate them on side effects and just what things are going to look like. Um, Obviously, it's different for every patient. It's very treatment regimen dependent on how how long you're sitting there in the chair. When you get chemo, side effects are all kind of the same. You can kind of like narrow them down to nausea, vomiting, constipation, or diarrhea. Um, Definitely fatigue, and then all the random side effects that we've come to know and love. Um, but yeah, that's kind of the like introductory phase of where I come in contact with the patient.
Yeah.
Um, yeah,
Yeah. Yeah. I actually, it, how people find out they have cancer can be so varied. Um, I
yeah,
actually was working with a patient. He came in and was complaining of some really, really weird symptoms. And so we were able to get
yeah,
him connected to a primary care doc who ordered some testing, and they found a tumor on his bladder and were able to resect it. And he did not need chemo, as far as I'm aware. But
yeah,
it is really interesting how varied people's experience with um, I feel like when we say cancer, kind of everybody gets has
yeah,
a picture of what that means in their head, um, but
yeah,
it can be so varied from very benign cancers to very malignant and aggressive cancers, different stages,
yeah,
obviously, but then also treatment can look so different based on the individual. Um, what
yeah.
what in your mind is a successful treatment for a patient that you're seeing coming into the infusion center?
Um, Sorry, I'm going to go back because I liked what you said.
Yeah,
It's very variable. I only mentioned the ER route of finding out you have cancer, but there's so many variables to somebody just getting a mammogram or getting their
yeah,
routine
yeah,
colonoscopy. Um,
yep,
so I think in the and we'll come for full circle on this, but in the suffering realm of things, it's very different because I think some people, when they go to the ER, they're like, I know something's wrong. I'm expecting to find
yeah,
something. And then there's the
hmm,
people that are like, I'm doing my mammogram because I turned 40 and that's what we do. And oh, surprise, there's something. And then kind of the downfall from that. Um, anyway, we'll come back to that. But
yeah,
you
yeah,
mentioned successful treatment. I think straight away, just being cancer free, getting into remission would be the quote unquote success. But there are a lot of cancers that aren't curable, and we
yep,
have to approach it from a palliative. Chemo will shrink tumors, and then that will lead to less pain and less symptoms and less complications, which you could view as success too.
yep,
So that's kind of a loaded question, but I think the overarching success would be remission. It
yeah,
would be your like typical 42-year-old female patient, breast cancer, shocks their life, shocks their world, but you get them through their year or two of treatment, and then you're seeing the oncologist once a year, and then every 5 years, and then that is like my top success, I would say.
yeah,
But yeah, there's little victories along the way too, with
yeah,
yeah, pain relief or um, all the different levels to that. So
yeah,
yeah,
yeah, yeah. Success is such an individual. I mean, I used it for a reason, right? But it is
yeah,
individual, both in treatment plan, and people can choose not to have treatments because they have a different idea of what success or what
yeah,
health or um, whatever that means, whatever any um, what they want for themselves and what is best for themselves and what is success is to them. Um,
yeah.
uh,
Getting to know, getting from the oncologist perspective is everything because if you're not on the same page with what the patient wants, you're not going to find success. So I think I mean, I know our docs do a good job of that, like determining what the patient wants because patients come in with preconceived notions and they say, absolutely not, I'm not doing any chemo. And then it's like, all right, well, that drastically changes the direction of the conversation.
Yeah.
And I feel like on a weekly basis, I'm reminding patients that their voice is the only voice that matters. If they don't want to do treatment, they don't have to do treatment. And as a healthcare provider, I'm not the doctor, but reminding them that they have the choice. They don't have to just do whatever the doctor says because they went to med school. Like there are options, and those are some of the most kind of powerful moments I've had with patients. Is when I say that, and that's like the first time they've even considered that they don't have to do what the doctor says. I think
Yeah.
medicine in general kind of has a almost bad rap of like, doesn't matter if doctor said to do it, so we're gonna do it. I'm not gonna research these meds. I trust the doctor. And there's a time and a place to trust the experts, obviously, but also getting to actually think through the decision you're making, I think, is huge, and goes a long way. So
Yeah. Yeah, 100%. I think also um when it is certain illnesses, um people feel so powerless, and I just can't think of
yeah,
an illness like cancer that does that. Like
yeah,
maybe like HIV AIDS makes people feel powerless, but even now like treatment has come so far for something like that that since 40 years ago, things are
yeah,
just so different, that and have advanced so much in the way that HIV is treated, that that one, while still carrying a lot of stigma and things like that, that I think are folks in our generation are trying to destigmatize things like that, on standing on the shoulders of giants from the generation before us. And Yeah, but cancer is this
oh,
life-changing diagnosis, and
yeah,
even just the word itself can have a evoke like a visceral response for people. And so I think with that, just that diagnosis, people feel so powerless, and getting to remind them of their agency is that matters. That matters.
yeah. Well,
So
with cancer and what I've noticed with patients, it's like typically, typically, they haven't done anything to receive this diagnosis of cancer. There's
yeah.
variables and factors of smoking and overweight and all the above, which we can get into. But for a lot of the patients I've come across, this is one of the first times in their life that they have no control over what is happening, um, which can be very hard, obviously. And depending on your personality type, that gets even harder for the
Hmm.
control freaks out there. It's like the first experience in their 50s, 60s, 70 years of life that they haven't had a say in how things are going, and that can be pretty jarring, off the start of things, which is tricky. So yeah,
Yeah. Yeah. Um, so I've kind of like to start taking this different approach to these um, examinations of suffering, where start very broad and then start to
yeah,
like kind of zoom in, come a little tighter, get a little more granular. So kind of rewinding with some of what you mentioned. So a lot of these patients Actually, at this point, every patient that comes to you already has the diagnosis, has already talked with a treatment over a treatment plan with an oncologist. Are
Yeah.
those oncologists, are they in the building with you? Are they in a hospital that you're associated with, or are just all of these hospitals referring people to you um, for chemo infusions?
Yeah, we have our oncologists are on site.
Okay.
We're fully outpatient, so our oncologists are across the hall from the infusion room, which
Mhm.
is nice. So
Yeah.
yeah,
Yeah. Yeah. Okay, so they've gotten this diagnosis. They've got developed a treatment plan with their oncologist. When they come into you, it sounds like they've probably already been in your building at this point. But take me through, like, they walk through the front doors. What do they see? Who are they interacting with? They're going into this 30
yeah,
chair room. What's all of that like?
yeah. At this point, most every patient has been kind of like walked through the infusion room and kind of has a brief overlook of what the day will look like. But even just the little things, I'll grab them from the lobby. They checked in with the front desk, um, walking them back and just showing them like we have an open chair policy, so we just walk back and say, "Pick a chair. I'm on the right half of the room with my computer's on this side, so any open chair is yours." Eventually, patients get very particular with which chair they like. If they want the one on the window view, we're on the fourth floor, and the one side wall is all windows, which is a pretty cool view. Um, and patients like to be right up against the window, but there are patients that want their back on a wall and don't want anybody walking behind them. And yeah, so they pick their chair. I guess I start pretty basic. Like, here's the bathroom. Here's our little snack area. You're gonna be free game to do what you need to do while you're here for X amount of time. Um, Timing is typically the first question they have, because doctors are famously terrible at knowing how long things take.
Yeah.
So that's typically the first like impression I have of a patient is, hey, you're going to be here for about 3 hours. And if they weren't expecting that, that can either like derail their experience, or you kind of learn very quickly what patients are like when you give them news they weren't expecting.
Yeah.
um, which is great introductory, like, who are you going to be? What are you going to be like? And at the same time, how do I educate you? How do I approach this time with you? Because everybody's different, and yeah. So walk them in, get them seated, walk through the timing of what their treatment will look like. Most of our patients have chest ports, implanted ports that we are able to poke our needle in, and we can get blood draws from the ports, and then we do all the chemo through the port. Oftentimes, too, that if they don't have a port, we'll just do an IV. So we'll go through that process, which, as you know, can be very quick and easy, or it can be very difficult
Hmm.
depending on their vein status and the joys of
Yeah.
that. Um, so usually those are the two big hurdles: is the timing, how long I'm going to be here, and then getting either the IV or the port. Sometimes, if it's their first chemo, that's one of the first times their port has been poked and accessed. And so that's a big education piece about what that will look like. Um, and then getting into the details of, this is your chemo, these are the side effects. Our clinic does a really good job of educating patients before they get to me in terms of side effects and what to look for, what to watch out for, what is a concern, and what is just normal side effect. So that's really nice. I've worked at other clinics that it's like they sit down in the chair and they're like, chemo? Like, am I getting chemo today? And you're like, oh boy.
Yeah.
And that's,
Yeah.
but our clinic does a really good job. They have a specific chemo education visit with a nurse practitioner where they'll sit down for an hour and just give them endless education about what to expect side effect wise, because that's typically the next big hurdle is patients being concerned and scared and worried about the side effects to come. Um, I think Hollywood has done a really good job of convincing patients that the second they get chemo, they'll be throwing up until their next treatment, which is just not the reality of chemo anymore. Our antiemetic nausea meds have come a really long way. Even since I've started working, they've changed and have become much more effective and last for a longer time after treatment. So oftentimes patients will come back for their second or third treatment and be like, I was surprised. I felt so fine. I wasn't throwing
Yeah.
up every 5 minutes. Um, so that's an education hurdle too. Just like, or they'll say like, yeah, my dad went through chemo 40 years ago and had this experience. And it's like,
Yeah.
could that be your experience? Yes, but we have new tools and new meds and new things to kind of minimize those things. Obviously, it still happens, but um, yeah. So that's kind of the like bringing back process. I try to be as approachable as possible. I think different. I think every nurse would say that, but I think being a listening ear first is step one and the most important. Um, so before I even describe anything, my go-to is to just say like, "Hey, before I just totally bombard you with information, what questions do you have?" Because as you know, working in healthcare, patients will be like, they'll start talking, and then 20 minutes later, they'll be like, "Oh, I forgot to tell the doctor about this." And you're like,
Yeah.
"Oh my god." So I mean, and the
Yeah.
prepared patients will write things down and kind of have questions marched out. But I like to start there and just say, hit me with your questions. If you don't have any questions, I'll just over explain everything and we'll get into it. Stop me at any point.
Yeah. Yeah.
But
Yeah.
that's the kind of direction that I've had success with. And going back, it kind of helps you learn who your patient is, what their education level is, what their tolerance to new information is. Because some people aren't ready to hear anything and process anything. They just kind of want to get it done and get it over with, and that's fine. Um, but yeah, you learn pretty quickly if you have a like older veteran patient that's like, don't care, dude. Just get me out of here,
Yeah.
basically. My
Yeah.
ride is coming at noon, and if I don't make my ride, I don't get to bingo and all these things. And then you have other patients that are just want to talk and want to over analyze every possible side effect and every little detail. So yeah, you learn pretty quickly though what type of patient you have, as you know.
Yeah. Yeah.
Sorry, that
Um,
was a long way to describe how I walk them back to the
no,
to the
that's
chairs.
honestly, that's perfect. Yeah. I mean, that's what we're going for here, right? Is to get granular. And some of this will come up um in the next part too, where um I'll save that question for a sec. But so thinking about like the port, or having to get IV access or something to give this medication. Actually, uh, my friend who recently had a stroke, is an RN and has given medication IV multiple times, countless times, right, as an RN, uh,
Yeah.
and got some IV Ativan before his CT scan and was like,
Nice.
dude, that burns. Like
Oh,
it felt awful. And now I have more empathy for them on like how it actually feels to get this medication pushed. And I will always dilute that. Not that we're ever giving Ativan in our clinic. We don't even have that medication, but you know, it's a helpful frame to think through. Okay, I'm going to give this person medication. What is that going to feel like?
yeah.
When you're doing the infusion, is the medication cold? Is it warm? Does it give them some? So, like, I'm thinking when I give plasma and they reinfuse, I get like all tingly and funky and it's
Yes.
cold.
Yeah.
What is it like for these folks when they're getting their infusions?
I mean, yeah, cold. It's definitely cold just because the chemo and the fluid that it's mixed in, saline or D5 or whatever, is room temperature, which is 72 degrees, and our bodies
Mm-hmm.
are hovering high 90s. So that's a 20 plus degree difference. So it makes you chilly pretty quick. We have blanket warmers that are the star of the show, and
Mm-hmm.
patients love their blanket warmer. Man, the warm blanket goes a long way.
Yeah.
Um, yeah, it can be definitely cold. For new for new treatments, we're always thinking, and I wouldn't say concerned, but thinking through what it would look like to have a kind of hypersensitivity reaction to the meds. Um, there are chemos and other meds we give that are more likely to cause those symptoms, which would look like flushing, chest pain, shortness of breath. Um, Oddly enough, an infusion reaction that is not common, but if you're going to react like the worst back pain you've ever had, um, which is so weird. I still don't know the pathophys behind that, whatever.
Yeah.
But yeah, so those are kind of always in the back of our minds. Going back to like when you learn who your patient is, you learn how much you're going to tell them. Obviously, we're going to educate them to what we think they need to know, but there are different ways to approach, like, hey, you've never seen this medication before. There's always a chance your body rejects it and you have the shortness of breath or the throat tightening up or that back pain. Um, and I've learned many different ways to express that conversation. Because, again, going back to the older veteran, I would keep it pretty simple and just say, like, hey, this might happen, but not worried about it. Let me know if you feel any symptoms. And then for the anxious young woman, it's a different conversation of approaching it with much more, I guess, compassion and um, still educating what could happen, but being much more soft about it.
Yeah.
Um, our patients we have little like pager buttons, and all the nurses wear pager watches, and then having that conversation with them, like, if you're feeling any of these symptoms, you hit this button and you're going to get 6 nurses around you in about 8 seconds. um, and if you're feeling something funky, we need to know about it, because the sooner we know, the sooner we stop the chemo and give you Benadryl and give you more steroids and kind of reverse those symptoms. But yeah, I think as far as feeling it, the cold is a good point. The tricky thing with chemo is a lot of the side effects are in the like 6 to 10 day range after
Right.
they've received the medication and it's kind of been processed by your body and has had time to um, cause the neuropathy and the fatigue and the nausea. Because chemo's kind of targeting and killing the fast growing cells because that's what cancer cells are. Um, and so that's where most of the side effects come from is it's killing the fast growing tissues of your GI system, killing the cells in your mouth, and that's where the mouth sores come from. Um, and that takes time. That usually doesn't happen like while they're with me.
Right.
If they're having any
Right.
sort of reaction with me, it's because it's like an allergic type reaction of their body basically saying, don't like it.
Yeah.
um, by the time we give the Benadryl and give the steroid, we get them back to baseline pretty quick. There's obviously a once in a blue moon situation where we have to escalate to EMS or send the patient to the ER. Knock on wood, that doesn't happen very often. Now that I
Yeah.
said it, it's going to happen tomorrow, but that's just how things work. um, so, yeah, hopefully that
Yeah.
answered the question. But
No, totally. Yeah, 100%. I think I think we probably, like you said, Hollywood does give us an idea of what emo is or looks like. And it's kind of a sensationalized uh, look into it.
yeah,
And so getting like the very specific details and hearing um, this is what it's actually like.
yeah,
Um, because everybody knows somebody who's had cancer at
yeah,
this point. Maybe even know people who have ongoing treatment for cancer or something, right?
yeah,
And so I think it kind of gives us a better picture into our neighbors' lives when we know more about this kind of stuff.
yeah,
And I think maybe one of the helpful things would be to hear some more about what the experience is, less from like a treatment and side effect side, but more on like the emotional experience side. They've received this diagnosis and talked through it with an oncologist, so probably at this point they have, like you said, processed through a lot of things, but um, there are always changes and life doesn't stop just because you start cancer like chemo, right?
yeah.
So um, I guess there's layers to this question. Are people coming in alone and like going through all of this on their own? Are does that make you as the nurse then become the primary person to process with? Um, what are they processing? Uh, yeah, go ahead.
Yeah, I think like I mentioned, they've kind of processed like the diagnosis, but all the unknowns of what treatment will look like, how they'll feel, if they'll be sick and throwing up the whole time, if whatever that looks like is kind of the processing that starts to happen as I start talking to them and start giving them their treatment. And then also like firm recognition that life is going to look different. Like I
Yeah,
am going to lose my hair, and I knew I was going to lose my hair, but I didn't process that until I'm here sitting in this room with other patients in wigs. And um, so I think that kind of makes it the next level of real. And sometimes that can bring out more emotions of like,
mhm,
do I want to do this? Obviously, they showed up, and that's step one. So that's kind of like, all right, here we go. Um, to answer your question, a lot of people do come with somebody, that being their spouse or their kid or a friend. Um, I would say it's probably close to like, I don't know if an estimate helps, but probably right around 50% of people have somebody with them. Um, Sometimes that's really helpful to have somebody to talk to, have their friend or spouse to help process these things. Sometimes it is not helpful, and the spouse is kind of projecting their emotions into the
Yeah.
situation, um, because something I've noticed is spouses don't always have the like processing done before they're there, if that makes sense. Like the
Sure.
husband will be there with the wife and they haven't processed like, oh, she's going to lose her hair, or oh, she's going to be so tired that I'm going to be doing all the chores and the cooking for the next couple months. Um, and that can be expressed in many different ways. You'll encounter many different emotions and many different dynamics. There's the like denial dynamic that I see from husbands a lot of like, I'm just gonna sit here, hold my wife's hand, and kind of get through it. And then you get the other side of that of the husband that is like overbearing almost and like, tell me about this and why are you doing that and what fluid is that? Is that saline or is that? And it's like, I understand. Like, this doesn't matter. Like, and it's hard to tell somebody that in a very nice way of like,
Yeah.
I know you care. I know, like, I know you're here for your spouse. Um, so that can be kind of tricky. I had a guy, uh, yes, not yesterday. Today's Monday. Last week, he like interrupted me. His wife was getting treatment. I was with a different patient, like two chairs down, and he like storms over to me as I'm about to poke this other patient, and he's like, "Dan, Dan, Dan, I gotta ask you something." I'm like, "I'll, I'll be right there. Like, let me finish what
Yeah.
I'm doing.
Yeah.
I'm literally talking to this other patient." So I
Yeah.
finish what I'm doing with the patient. I come over to him and his wife, and he's like looking at the bag of chemo, and he's like, "It's not dripping. It's not going." And I'm like, that's the saline that's clamped right now, and eventually we'll rinse through all the chemo. This other bag right next to it is the chemo, and that one's dripping. You're like, you see the drops coming. There you go. Um, and that was probably his way of just like trying to protect and trying to
Yeah.
be the voice for his wife. And it was funny. His wife was like, "I told you." um, so yeah, if they come with somebody, I like when they come with somebody. It's a second set of ears. The patient is hearing a lot of new things and processing a lot of new things and learning about side effects and how to take their nausea meds and how to take meds to slow down diarrhea and whatever that looks like. Um, and so I think it's great to have a second person to kind of help remember the details and remember the little things. Us that do it every day and we work in healthcare, it's an easy like, what do you mean? Like, it's easy to take your meds. You do it at this time and it says it on the bottle. But patients can get overwhelmed and it gets turns into a mess of like, so when do I take this med and what does PRN mean? And um, those little things. But yeah, bringing somebody with them um, can help a ton from an emotional standpoint. There are also times where we've asked their visitor to wait in the lobby um,
Yeah.
because all they're doing is overwhelming the patient and making things harder and worse than it needs to be. Um, so there's many different levels to that, but yeah, the emotional piece of it is huge. It's almost kind of one of the, I don't know if there's any like data to back this up, but I feel like it's one of the final stages in processing their diagnosis when they get to me, because it's the like they've gone through the stages of grief in some ways.
Sure.
They've had their denial phase of there's no way I have cancer, and I'm blanking on the phases, but you know what I mean. They kind of it's that like final straw of like, okay, we're doing treatment, and this is what the next few months are going to look like, and it's not going to be easy. We'll get through it, and we're here with you to get through it, but it's going to be hard. It's probably going to be the hardest thing you'll do in your life. So
Yeah. Yeah.
hopefully that.
Is that a conversation you have with people is like, hey, this is really hard and this might be the hardest thing you ever do?
I try to, yeah. I It goes back to kind of learning who the patient is, learning
Sure.
their kind of grasp of the situation. Um, but patients, I feel like patients have a kind of mindset of like we're there to give them the chemo, and then they don't see us again until their next chemo, which is not at all true. We're constantly doing IV fluids and electrolytes and IV nausea meds and blood draws to see how their body's handling things. So that's a piece I really try to hammer home. Like, you're not alone. We have
Yeah.
6 triage nurses that their only job is to answer your phone calls, answer your questions, and there's no question that's too dumb. There's no symptom that's too like stupid to ask about. But if you're worried about it, call us and let us decide if it's something to be worried about or not. So yeah, I try to have that conversation a lot, because they often feel like we're just the poisoners. We just give them the chemo and ship them home to suffer, and that's not at all the case. So yeah,
Yeah. 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 That's actually really helpful. I think that's where I guess I'm curious how you see your role in this, right? So suffering does something, and it doesn't just do it to the people who experience it. It's happening to them, but it also
yeah,
does something to the people who witness it. And it also does something to the people who step into the suffering, right?
yeah,
And so for you as a nurse stepping into this profound suffering in the Cancer Infusion Center, how do you think of your role there? Um, how do you think of your role as the RN, as the person kind of guiding this patient through one of the hardest things they'll ever go through? Um, yeah,
yeah. For me personally, I think it would be interesting to hear like my coworkers' answer to this question. Um, I think every human, every nurse approaches things differently.
yes,
But for me, I think being like a happy, positive light in the dark situation, I've found a lot of, I don't know if success is the right word, but a lot of feedback that is beneficial. Um, there are probably patients that like haven't had anybody smile at them in weeks, like,
yeah,
and that is sad, yes, but they're in such a dark season of suffering that, um, to have somebody be positive and encourage them and just kind of be there with them. I know that's kind of a lame answer to just be with them, but to just be able to listen, which is hard for some of my coworkers, especially. That's hard, but I digress. Just listen and be able to like process with them like what's going on, um, and have a positive spin on it. I think that can sometimes get me in trouble in like my personal life of like everything's fine, everything's gonna be okay. I'm a very optimistic person, um, and in small doses of like patients going through chemo and the suffering that ensues, it can be helpful, and I've noticed it being helpful while also being practical and being, I mean, I'm not blowing smoke and telling them they're gonna feel amazing and no, you won't lose your hair. Like I'm not lying to them,
Yeah.
but just
Yeah.
being able to like partner with them, and sometimes that's sitting with them and just holding their hand while they cry, or um, giving them a ginger ale with ice. Like there's so many different ways that that comes across, but I think ultimately presence and
Yeah.
um, positivity can go a long way, especially in the day and age of technology and resources. And patients can go on Google and find the answer they're looking for, which can be very scary. And they can look up their drug and see the black box warnings of death and
Yeah.
interstitial lung disease, all these things that can be so just dragging and just kind of dig dig you into a deep pit of despair.
Yeah.
So I try to be positive. I try to, once I know patients, like if I can joke with them, and kind of approach things that way, great. Oftentimes it's just listening and saying and being real and saying, hey, this is terrible and I'm so sorry you're feeling terrible. Um, Here are some practical solutions. And if that doesn't work, we got other solutions and we'll try different things and get you through it. It's not going to be there's not always a quick fix. There's not always like a instant band-aid situation, but being able to kind of go in the trenches with them, and oftentimes it can be tricky to like compare other patients situations with the patient I'm in front of, um, because everybody's experience is so different. So I don't do
Yeah.
that very often of like, well, Jan was in last week and she's doing great. You're going to do great too. I, I, I try to avoid that, and put different kind of positive spins on things because you just never know what things are going to look like. I think patients like to play that game. They like to be like, so how many of these treatments do you give per week? And then they kind of like go down a rabbit trail of like, how are those other patients doing? And is this normal? And those sort of things. But
Yeah.
yeah, being with them, listening, smiling, encouraging would probably be my answer. Yeah.
Yeah. Yeah. I what I hear you saying without saying it in so many words is like meeting people where they're at. So whether that's
Yeah.
telling them as much as they want to hear or as little as they want to hear, meeting them with the
Yeah.
positivity that they want, the jokes that they want, like meeting people where they're at. Um, and
Yeah.
I imagine, just because I've known you for long enough, that you're actually really, really adept at meeting people where they're at. And it I think it makes you the right guy for the job. Um, I think you're really probably really really good at it, and really good at your job because of how good you are at being present and meeting people where they're at. What has it been like for you to be so close to such profound suffering?
Yeah. Kind of back to my like, I call it my toxic positivity. That's what I tell Kenna all the time too. I just, I mean, not to go too far back in the old childhood days, but I my dad's a pastor. I'm the youngest of five kids, and I had to learn pretty quickly, like, you're gonna be along for the ride. You're gonna choose joy was a kind of phrase my family always used, which now is kind of coming out as that did more harm than good. And some my siblings have kind of expressed and are dealing with my parents through a like, hey, it's okay to be sad. It's okay to have emotions. It's okay to cry. It's okay to not be up for going somewhere, doing something. So that's kind of like my foundation that I've had to kind of break free from in a lot of ways. There are definitely pros to that, because at some point you do have to kind of detach from your workplace. And if I carried the weight of my patients and their emotions and their suffering, I would simply just not be a human. I would come home and crawl into bed, and that's it. So there's a piece of that where I've had to learn how to like branch things a little bit in terms of like, hey, I can be sad about this, and I can like process these emotions with my patients, and then on my bike ride home, I can process like how I'm feeling about those things and if there's anything I can do about them. And oftentimes it's just kind of like a let it go and move on. And I don't know if that's a healthy way to do it or not, but that's what's worked for me, just because I am a feeler as a person, and I I feel alongside people. I hurt alongside people that are hurting, and that can be consuming if you're not careful. Um, so I think for me, I've had people to talk to. My coworkers are great. I think healthcare workers kind of have a dark sense of humor, which can be helpful as long as it doesn't cross any lines, which it does. But so I've kind of pressed into my more wise coworkers, I would say, and my nurse pals that have been nursing for. I work with people that have been a nurse longer than I've been alive. Kind of picking their brains of like, how do you not let this affect you? Like, how do you move on? And we have our patients pass away. That's every healthcare worker, but especially in the oncology world of things, we get weekly cards that go around. Everybody signs them, the patient's name, and um, which is actually a really, really helpful kind of closure. Um, we don't really know that they've passed until we get those cards, especially from the infusion nurse perspective. We just kind
Yeah.
of like stop seeing the patient. And for our like really well known patients, people will remember and be like, hey, we haven't seen Greg in a while. But oftentimes it's coming across those cards. And we often sign them all together, which is really kind of a powerful moment of closure and like um,
Yeah.
remembrance of the patient of like, oh man, Tim passed. Like, that's so sad. And I wonder how his wife Becky's doing. And then we get to kind of just touch base on stories we remember of Tim, and like, I can't believe he had 6 packs of pistachios every time he came into the clinic, and then laugh about that. And So that's a really like practical way that I've kind of dealt with the emotions of working in this field. Um,
Yeah.
but it also gives me some deeper perspective on being really thankful for every day I wake up and have a able body, and um, just those little things that are a kind of a constant reminder of I'm healthy and I have a beautiful family and a beautiful home. And so in a different way too, it almost kind of points me back to that constantly, which can be helpful and can kind of remind me of how blessed and how fortunate I am. So
Yeah.
yeah,
Yeah. Yeah, that's cool. I think yeah, I think there is a weightiness to making yourself close to suffering. And I do yeah, I see how that weightiness can become um so much of a burden that it becomes all consuming. And um I actually years ago I listened to a podcast. This guy living in Europe used to walk um, to and from work, and specifically the reason he did that was it gave him space to um, not exactly compartmentalize, but essentially compartmentalize, where you've like I've processed what's happened at home, and now I can go be better at my job, and then
yeah,
I can process what's gone on at work, and I can be better at home.
yeah.
Um, and
And it
that
goes.
is it does, yeah, 100%. Um, yeah, and there is so much to learn from being close to suffering,
Yeah,
and it does there is a gratitude that comes with having seen such suffering and recognizing, oh, I'm not, whatever this is that's going on over here is not a cancer diagnosis. It's not chemo. Um,
yeah,
uh, yeah, yeah, that's cool. Thanks for thanks for coming on and giving us a picture into what it's like to be a cancer infusion nurse and representing your patients and telling what suffering looks like for those folks. I think it makes us all better people. Appreciate you, Dan.
yeah. Love you, bro.
Love you, man.